Acute peritonitis, a common mechanism. This is the first in a series of podcasts on acute peritonitis. What would I like for you to get out of this session? The most important learning point actually is to develop a conceptual framework for intra-abdominal disease processes. I want you to think mechanistically and focus on the pathophysiology to create a story or a script of how a disease occurs and progresses. It should be something that actually makes sense and adds on to what you already know about human anatomy and physiology. You're much more likely to understand and retain this information with this type of approach in contrast to trying to memorize random facts. A major caveat to this is that these frameworks are inevitably oversimplifications and somewhat imperfect descriptions of what's happening. However, they do provide a starting point for you to help you organize your thoughts and learn. Think of them as cognitive lenses through which you can view these disease processes. There will be cases that don't follow the story perfectly, and these should be not viewed as random exceptions to the rule, but rather as variations that highlight other factors that alter the course of disease in human beings. Today we'll look specifically at biliary colic and acute cholecystitis, as well as appendicitis as illustrative examples of a common mechanism of disease. The first shift in your understanding of human physiology that I would like to try to achieve is your view of the human immune system. Typically in medical school, you learn that the first responder to injury and infections are neutrophils. These are very interesting cells that do a lot of things. But what's underappreciated is that our first line of defense is a barrier mechanism, namely the skin, the epithelia. Granted, squamous cell epithelium are not nearly as interesting as a neutrophil from a cellular biology standpoint, but they are arguably actually the most important component of the human immune defense system. This defense barrier actually extends throughout all our orifices and passageways that are in contact with the outside world and therefore are at risk from hostile elements. For the gastrointestinal tract, the columnar epithelial cells provide a robust wall to keep out the pathogens that are ever present in the lumen of the bowel. These cells are able to maintain integrity of our intestinal wall unless an especially powerful pathogen overwhelms them, such as Salmonella or Clostridium difficile, or when their lumen or when their integrity is compromised, as we will see in the following slides. So I would like you to recognize in the first part of this session that human bodies, the most important layer or the initial defense layer are our epithelial lining, whether it be squamous of the skin or the columnar of the GI tract. And these are very robust systems that help us and protect us from the ever-looming threat of pathogens. So if you look at this picture, this is the common mechanism that leads to the breach in the epithelial barrier. And what you're looking at is a blind lumen with an obstructive lesion or a process. So it's a blind lumen with an obstruction. And if you look at the shape, think about what it reminds you of in terms of structures that you know about in the human body, particularly in the gastrointestinal tract. So this should help you help you recognize what some of the structures we're talking about. A obstructed blind lumen, this type of situation can occur in gallstones or in the gallbladder, in diverticula of the colon, and in the appendix. And as you know, these are 3 of the most common causes of acute abdominal emergencies that we encounter. But let's dig a little deeper. Rather than just recognizing or trying to memorize that obstructed blind lumens are bad, we need to develop a coherent story of what actually happens once a blind lumen is obstructed. Okay, so we should go over step by step what actually happens. A blind lumen, an obstruction of a blind luminal structure does not equal inflammation and infection. It does, but that's not the way you should think about it. You should think about it as obstruction leads to typically distension, and the distension creates pressure, and it is this pressure that blocks venous outflow and flow into the capillary, which essentially creates a compartment type syndrome, and that prevents delivery of oxygen to your epithelial cell layer. And this is what causes a compromise of the wall and causes our defenses to crumble. And when this happens, then the luminal bacteria can infiltrate into the deeper layer, resulting in inflammation and infection, and even possibly to necrosis and perforation. Now, most of you understand visceral and parietal pain and the classic history of migration of pain from the periumbilical region to the right lower quadrant and appendicitis. And you also understand what happens when there's free perforation, that there's diffuse peritonitis. So let's use the example of appendicitis to correlate your understanding of a clinical presentation in terms of what the patient experiences with regard to pain and their presentation to what's actually happening at the level of the organ. So when the fecalus obstructs the lumen of the appendix, the distension and pressure activates visceral pain fibers, which will result in pain. This type of pain is visceral pain, and typically it's in the periumbilical vague, probably on the milder side. And then as you go down past the pressure and you start developing ischemia and then infection and inflammation, that's when the pain becomes more intense, and the pain also starts to become more localized to the right lower quadrant with tenderness, as the full thickness involvement of the inflammation results in activation of pain fibers along the parietal peritoneum as well. And if the appendix perforates, and if it has diffuse spillage, which is not that usual for appendicitis, then the patient will experience diffuse parietal pain and has signs of diffuse peritonitis. What about the gallbladder? Well, the gallbladder also reacts to luminal obstruction, but unlike acute appendicitis in the appendix, the process that occurs after the obstruction can often be reversible. So once the stone obstructs the gallbladder, the person develops visceral pain, as would be expected due to the increase in pressure from a combination of luminal distension as well as contraction of the gallbladder wall itself. Now, if the stone dislodges, the patient should start to feel better, and then the episode is terminated, and this event or this episode of pain and obstruction is called biliary colic. However, if this process continues because the stone does not dislodge and the prolonged wall tension leads to ischemia, which leads to compromise of the integrity of the epithelial layer and infiltration of bacteria leading to inflammation and infection, the patient now has acute cholecystitis. And this slide illustrates that process in the stepwise fashion, with obstruction leading to distension, leading to pressure, localized compartment syndrome type of physiology with ischemia, resulting inflammation and infection for acute cholecystitis, whereas biliary colic, because the stone is dislodged, it never gets to the part where there's actual inflammation. Okay? And the more severe cases of infection and inflammation leads to necrosis and perforation. So now let's think about the clinical presentation with somebody with acute cholecystitis and biliary colic. Since the gallbladder is in the foregut, the patient is likely to start out with visceral pain over the epigastric region or the right upper part of the abdomen. Now, what differentiates from biliary colic and acute cholecystitis from a clinical presentation is the presence of systemic signs of inflammation, but also the duration, meaning that there's going to be a longer duration of pain because the stone hasn't dislodged. So the pain often lasts more than 4 hours, and then the systemic signs that we look for are fevers, tachycardia, significant tenderness, and leukocytosis. Now, with regard to radiographic findings, there is radiographic evidence of inflammation which manifests as edema and fluid. So the picture on the right shows acute cholecystitis with a thickened gallbladder wall, which is caused by fluid within the wall of the gallbladder and the interstitium. And the blue arrow points to a sliver of pericholecystic fluid, so additional exudative fluid from the inflammation. On the left is a normal gallbladder with just a stone. It could easily have been a picture of somebody with biliary colic where the stone now has been dislodged and now the patient is feeling better. But there's no evidence of inflammation. The wall thickness is normal. There's no fluid. So as we wrap up this session, I hope you are starting to develop a better understanding of a key mechanism, specifically that an obstructed blind lumen leads to pressure. Pressure leads to diminished perfusion. Diminished perfusion of our defense system leads to infection and inflammation. It may seem obvious and it may seem simple, but it's a very important point to not think of acute appendicitis or cholecystitis as an obstruction that inevitably leads to infection and inflammation. The stepwise progression is important for you to understand because that tells the story of what's happening. And you'll see as you go forward, there are these common concepts and mechanisms that really tie in a lot of pathophysiology in both medicine and surgery that will help you understand without having to memorize too many random facts. And it will assist in your acquiring and assimilating knowledge more efficiently. Thank you.